Dear Chair, dear colleague, it's really a pleasure for me to be here today and to speak to you about this topic. And I would like to start my talk with this title of this published editorial, Inflamming the Debate of Infantile Colic. Why? Because the research in infantile colic is in progress toward the etiology and also for target therapy. You know that the incidence of infantile colics range widely from 3 to 40%. And probably the intestinal flora may be modulated through the use of probiotic, and may be an indirect approach to influence the fascinetic and the time-distressing condition that worldwide affect normal infants. So you know that the early study that I show generate a great interest among pediatricians, but at the weakness not being double-blind, placebo-controlled. So this new study show the benefit of supplementation, which is clearly demonstrated, and also I want to show you the modification that occur in the gut microbiota. Now we enrolled 50 patients. The patient assessed for eligibility was 126. 25 allocated to lactobacillus reuteri, 25 allocated to placebo group. The primary outcome was the reduction in daily average crying time from baseline to the end of the treatment period, less than 3 hours per day. You can see a significant reduction in lactobacillus group. The secondary outcome was the number of responders in each group at day 7, 14, and 21. And this data confirmed the clinical equivalence between the parents of Lactobacillus reuteri and the daughter of the new strain evaluating this new study. You can see also in these slides the crying time per minute per day after 1 week, after 2 weeks, after 3 weeks. There is improvement after the first week of treatment. And as concerns microbiological analysis of feces, this is the slide where you can find the colony of Lactobacillus reuteri, recovered from feces of infant supplement in the supplemented group. This is very interesting in my point of view, because in this slide you can see that at the end of treatment we observe a decrease in the Lactobacillus group of Escherichia coli and an increase of Lactobacillus significant. This is the two data microbiological relevant. As concerns bifidobacteria, we observe an increase but not reach the significance. And fortunately, we don't observe any Clostridium. Our finding confirmed the effect of probiotic on colic symptom in breastfed infant, and we can speculate the possible mechanism involved may be an improvement of gut motility and function, and also involving the effect on visceral pain, because there are really experimental studies interesting on this topic. Kunz demonstrated that Lactobacillus reuteri target the ion channel in the enteric sensory nerve through the probiotic that may affect the gut motility and pain perception. Also, have been shown that Lactobacillus reuteri suppress the pro-inflammatory cytokine. And also there are evidence of the effect of probiotic through ingestion that can inhibit the red colon contracting activity by acting via the channel that current in the enteric H cell. And more recently, also the group of Kunz show in this very interesting paper that Lactobacillus species ingestion can decrease the autonomic response and fibrous spinal discharge of non-suggestive colorectal distension, even in absence of inflammation. You can see that when there is the presence of Lactobacillus reuteri, the stimulus of is nothing. So, in conclusion, there is growing evidence about the influence of probiotic on gut motility, the self-limiting nature of colic has precluded, of course, the use of invasive method to establish the pathophysiological model in vivo. But there is a complex relationship between the intestinal immune system and the commensal flora and motility, which require further research. But you know that some colleagues ask, we have to treat or not to treat infantile colic? And behavioral and pharmacological remedies have been studied and proposed as a treatment for infantile colic, but only few have been confirmed through rigorous scientific evaluation in the form of randomized control and trial. So the question is, what is the best treatment for infantile colic? As you have said before, infantile colic would be the early expression of atopic disease, and not also atopic, but also for gastrointestinal disorder. And this is a good argument for me for trying to treat colic and to reduce the baby pain and the parent discomfort. And in this slide, I want to show you a follow-up study performed in my hospital when we observed 10 years later what happened to child with infantile colic. And they are subject at risk for atopy disease, not also for atopy, but also for gastrointestinal disease, such as recurrent abdominal pain, and also for psychological disorders, such as interaction with other child, problem of sleeping, supremacy, and so on. And this is very, very interesting in my point of view. And in conclusion, considering the favorable course of the infantile colic and the wide range of manifestation, a self-therapy should be adopted, which is proportional to the intensity of infantile colic. And our result suggests a potential role of Lactobacillus reuteri as a new therapeutic approach for this condition. Thank you for the attention.